Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Paul Kolodzik has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
Well, guess what? We're almost at Valentine's Day, and we are here with a sweet gift for you. It's another episode of the Medibolic MD /CGM Doctor with Dr. Paul Kolodzik. Happy Valentine's Day, Dr. Paul.
Yeah, you got to watch those Valentine hearts, the candies.
I love those little things. I really do. I mean, I don't eat them much anymore, but those were, when you were a kid in school and you got a little box of those, weren't they the greatest things in the world?
Yeah, they were.
Now, do you remember being in school having a shoebox with a little slit in it and people would drop in Valentines?
Yes, I do remember that.
Yeah, and somebody would tape some of those little hearts to it.
I wonder if that happens anymore. Do you think that happens?
Well, my daughter's a fourth grade teacher. I should ask her.
Okay.
I asked her recently, do you do the hand turkey at Thanksgiving?
Yeah.
Where you draw a hand and you put. She says no.
Wow.
So I really have a problem with educational environments these days. All right. So today we're going to talk about something we briefly mentioned last podcast, which was if you're on medications, insulin, heart medicine, high blood pressure medicine, can you get off? And the answer is...
Yes, for many patients, not all patients, but for many patients with some conditions, there's an opportunity for what we call deprescribing.
Deprescribing.
Yeah.
Deprogramming, deprescribing.
Deprescribing, yeah. And I've, been able to coordinate with patients' primary care doctors and myself provide, a deprescribing approach for many, many patients over the years.
Because you believe as a metabolic physician, somebody who's focused on that area, no medicine is the best. Is that kind of let the body be itself?
Yeah, I mean, medicines can be great for some people when needed, but if you can manage your health issues with lifestyle issues and not require a medication, that's obviously a better option.
Now, let me poke at that just a little bit. People's lifespan used to be what?
45.
45,
okay.
Right? In the revolutionary days, you're lucky to live to 45.
Yeah.
Through the art of health in medicine, haven't we extended that?
If you look at that historically, the data shows that most of that increase in longevity relates to improvements in public health.
What does that mean?
Clean water, sanitation, nutrition. So it's not necessarily medical interventions.
What was that? There wasn't a plague, but there was something in early 1700s in England that they found to be an isolated water well somewhere in the middle of town causing the plague.
I think that was, I can't remember.
Yeah, I can't either, but it was a good one. I saw the movie on that.
Yeah.
So you're saying public health has reduced.
Public health is the reason for the majority of increased in longevity now. I mean, medicines and medical care and interventions and surgical procedures obviously have played a role. But, the life expectancy in the U.S. over the last few years has gone down.
Why?
One of the big reasons is the fentanyl issue. A lot of young people dying. Yeah.
Really?
Yeah.
That's amazing.
Yeah, it is amazing. But
so that brings the average down.
That brings the average down. But, yeah, the other is, what's happened with obesity over the course of the last 30 years, too.
So the previous podcast a week or two ago, we talked about GLP-1s lowering weight.
Yeah.
Don't you think that's just going to continue to increase the lifespan?
Yes, I do. I think GLP-1s will have a positive impact on both longevity and health, what we call health span, not just lifespan, but health span, being healthy as you age.
All right, so before I poked at your theory and my theory about people dying at 45 and now they're living longer. Tell me about how I get off medicines through some simple approaches that you might recommend?
Yeah, so the concept here is deprescribing, and it's that, and I think we ought to focus on two areas: blood sugar management, and then also hypertension.
Well, we just covered those. Okay, but keep going.
Yeah, so a lot of work I've done in my practice over the course of the last decade has focused on patients coming into me that are overweight, pre-diabetic, even diabetic, sometimes with what's called comorbidities. So you're diabetic and you have another morbidity issue. Morbidity means other illness.
Morbidity sounds like it's death.
Yeah. In this case, it's called, because it is negative if you have another condition.
Okay.
Okay. But basically, it's the diabetic patient that is also overweight and has hypertension. And so what we have focused on is getting patients off medications to the extent we can, or quite honestly, the other, earlier aspect of that is keeping people from having to go on medications. Let's talk about that for a second.
All right.
Okay, so I have patients that are pre-diabetic that come to me, and they understand that, they've seen other family members that are, long-term diabetics, dependent on insulin, maybe having peripheral vascular disease or kidney failure related to their diabetes, and they want to prevent that. And they're in that danger range of pre-diabetes. So before we even talk about deprescribing, let's talk about pulling people away from the edge there in terms of having that pre-diabetic avoid going on to diabetes.
So, okay. So basically when I became a diabetic, they prescribed me some medicine.
Yeah.
To hopefully not have me go over the edge, but I still went over the edge, and I became a full-fledged diabetic card-carrying member. So you're saying medicines can be used to pull you back and then get off the medicines. Is that what you're saying?
Yeah. Okay. So first of all, pre-diabetics can reverse their pre-diabetes completely and never go on to become diabetics. And the most effective intervention there is lifestyle changes. And again, we're going to talk about the same tools. Maintaining a stable blood sugar so that you're burning fat for energy rather than having excessive blood sugar available, intermittent fasting, and strength training, which decreases insulin resistance as well. So I have a lot of patients that are pre-diabetic come to me. Some may have been started on a medicine. The first medicine usually used is a medicine called metformin.
That's right.
Okay.
Yeah.
Or glucophage is the common brand name for it. And we're able to pull those people back from being requiring that medication and reverse their prediabetes. So you can do that both from the lifestyle changes and then also be able to get them off that medication.
Yeah, but as a diabetic, I'll tell you exactly what was in my mind. Here's a pill. They didn't talk really at all about, hey, you need to lose weight. Maybe they did. It's been 30 years, but it was, here's a pill. Let's check you again in a couple of months.
Yeah, think about it. Think about the health model that we have, Terry, where you go into the doctor for 20 minutes twice a year, and it's like there isn't much time other than to talk about, how we're going to tweak your medications or start this medication or that medication. It's not like what we do in my practice where we spend hours, both myself and my health coaches, talking about the lifestyle interventions that'll help you avoid ever being on those medications.
All right. So, but I'm liking what I'm hearing. So there's hope for people who get that diagnosis that they don't have to go over the edge. It's not inevitable they're going over the edge.
No, in fact, prediabetes, again, is reversible. American medicine right now treats prediabetes like, oh, yeah, we'll keep an eye on your blood sugar and then we'll just wait till you're diabetic and then we'll treat you. Whereas the approach, I think this is like a lights and sirens situation. If you're pre-diabetic, we should not be nonchalant about pre-diabetes. It's like it's the time to intervene before you go on to become diabetic, which is irreversible, as we'll talk about. I think can be put in remission, but once diabetic, always diabetic, I believe.
Okay. The other medicine that seems very common is statins and then blood pressure medicine.
Yeah.
So what is it the same?
So with
program?
Let's talk about blood pressure medicine first. Yes, if you can correct lifestyle factors, primarily being overweight, then you can get off blood pressure medicine. I'm not going to say every patient. Some patients have uncontrolled blood pressure, which is going to require medications, but I've gotten, hundreds of patients off antihypertensive medications with their success in weight loss.
Oh,
so yeah, you can get off many patients, not all patients, but many patients can get off blood pressure medications as well.
Okay. And same with statins?
So statins, from my perspective, is a little bit different story, because my personal belief is that statins are way overprescribed.
Is it the most prescribed medicine out there?
Yeah, I think.
And I think GLP-1s are coming close.
Yeah, maybe GLP-1s will overtake those. They probably will in coming decades.
But so statin is the darling of the medicine world. Right?
Yeah, I mean, and again, it's a medicine. There's a couple industries now that push it. The healthcare industry and the pharmaceutical industries.
Well, yeah, okay.
But statins, I think are overprescribed, and part of that is my belief that a bigger problem for most people than their cholesterol level is what's going on with their level of insulin resistance, and their blood sugar. But we've kind of got this knee-jerk reaction to, if your cholesterol's 210, then we're going to go ahead and treat it with a statin. And we've talked in previous podcasts, I think, that my personal belief is I don't think people should go on a statin until they know exactly what is going on with their subfractions of cholesterol. So this is the discussion of the subfraction of cholesterol called LP little a or lipoprotein A, or apolipoprotein B. So get your subfractions of cholesterol done if you have a mildly or moderately increasing cholesterol before you and your doctor decide whether you should move forward on a statin, which also can have significant side effects.
All right, so let me pause you and poke at you. We only have a brief amount of time on this version of podcast, but let's say somebody out there listening goes into their doctor and they go, "Hey, I heard this Dr. Paul guy tell me that I really shouldn't go on a statin or don't need a statin." What do they do if their doctor's only giving them 20 minutes and he's writing that prescription? So, do they take it? Do they do their own research? What do they do?
So first of all, I'm not. There are patients that need statins. I want to be clear about that.
Sure. Okay.
But the majority of people don't have crazy elevated cholesterol. They have mildly to moderately elevated cholesterol. And my suggestion to people is to probe a little bit deeper. And you're going to be pushing your doctor because they only got that 20 minutes.
People are afraid to push their doctor. It's a God complex thing. We talked about this briefly the other day. We think you guys got white coats, you're God, whatever you say is the rule. And we don't push back like we should.
Yeah, I agree. You need to empower yourself and ask questions. So I would say, quite honestly, if it's mild to moderately elevated, I would have the discussion with your doctor of, can we look at my subfractions?
So that's a question they should maybe say, can I run the blood test?
Now your doc, that's a complication to your doc's stay. Okay.
He's not going to expect it. He's not
going to expect it. It's like, oh, now I got to order this additional test. I'm going to have to see him back. And so it's a complication to your doc's day, but it's why nobody cares more about your health than you. You've got to push your doc. And one of a few things are going to happen. Your doc's going to be collaborative and say, yeah, let's go. We can go ahead and get that before we start it. It's not urgent usually that you get started on a statin.
Right.
Now, I will. An exception here is patients that have known heart conditions, because I'm going to exclude that group because statins have been shown to be effective in those patients.
Then I'm excluded. Okay, good.
With a pre-existing heart condition. But I would ask about subfractions, and if they don't want to do that, I would still probe deeper. I have a doc in town, Dr. Richard Saxon here in Dayton, who's great with patients.
What's his doctor? He's a certain kind.
He's a lipidologist.
Lipidologist. So if somebody goes in there, they may want to go see their own lipidologist.
Yeah, I mean, and if if your doc just wants to say, let's start a statin, and you aren't so certain, dig deeper, empower yourself, get the numbers. Now, you may end up getting the tests and find out that you do need to be on a statin.
What's the downside of a statin?
Well, there's a number of potential downsides. The biggest one is the muscle achiness that it can cause.
And I take one of those CoQ10s,
right? Which can help.
Yeah, it does help.
The other thing is that statins have been linked to long-term cognitive decline as well.
Oh man, you're stacking this up for me. I'm going to be in a problem. I got high blood pressure, high blood sugar. I'm on a statin. You're going to be visiting me in some home not far from now. Is that what you're saying?
Probably not.
Okay.
Okay. We'll do podcasts from your nursing home, Terry.
Sounds good.
So just question, and you may end up needing the statin, but I think there's a very large proportion of people in this country that are on statins that don't need to be on statins. So, this also then links back to this whole issue of I'm an advocate of low-carb diets, which are higher-fat diets. And if you go on a low-carb, higher-fat diet, is that going to impact your cholesterol? And, my experience over the years is, except for a very small segment of people, you don't see a significant bump in your cholesterol on a lower-carb, higher-fat diet.
Okay. Anything else we want to nail on this one before we say?
Well, we want to talk about the blood sugar issue, and again, in terms of patients that are already diabetic,
they've crossed the line.
Right.
They've got the card. They're a member of the club.
Right.
Yeah.
So there are some patients that will. So, and again, let's talk about the different degrees of this. Some just require medication. They might be on a GLP-1 medication. They might be on another oral medication that lowers blood sugar, or they may have progressed to requiring insulin.
Right, which I'm on, yeah.
Yeah, and what I've done in my practice over the course of the years with the diet and lifestyle changes, again, lower carb, intermittent fasting, we've been able to de-prescribe, we're coming back to that word, de-prescribe medications for people. So there are many patients, not all patients, I don't think you're in the category with the many years that you've been on insulin, Terry, but there are many patients that can get off insulin. There are many patients that I've been able to get their high insulin requirement down to a much lower insulin requirement. Maybe rather than requiring insulin 3 or 4 times a day, they can now just take the long-acting insulin in the evening.
That's where I started,
with good control.
Yeah.
And then other medications that they can. That we've been able to pull them back away from. And, I'm not going to say they're going to be off the medications forever, but for many years, maybe even a decade or more, that they can get off those medications.
So I was prescribed recently GLP-1 pill form.
Yeah.
I haven't taken it.
You don't take medicines your doctor prescribes, Terry?
Well, he said, you want to try this? I said, well, maybe. So he prescribed it to me, and I have the little boxes. I haven't opened them up yet because I just don't want to go through that nauseated period, and I'm on insulin now. I just don't know what the
Well, there is a nuance to balancing these medications in a combination of diabetic medications, because some people are on as many as 3 different diabetic medications.
Yeah.
So they've got to be integrated into a plan that's effective.
Well, it's funny. I went to my heart guy just a month ago, right, and said, "Hey, my family doc gave me this GLP-1. He said it'd be good for your heart." And he looked at me and goes, "You don't need that. You're on enough stuff as it is."
Okay. Yeah.
So that's a problem we all face. We're getting like this advice. We don't know what's right. Who's the best one to listen to?
You've got to educate yourself. Again, that's what educate and empower yourself. Research it. Ask good questions.
How do I know I'm not getting fake news?
Let's not get going on the fake news thing.
All right.
Hey, the one other de-prescribing opportunity often is hypertension. People, and I've had,
I can see that one.
Many patients that with weight loss, they've been able to get off their blood pressure medications, many completely. So that's another. If you've recently been diagnosed with hypertension, or you have stage 1 hypertension, even into stage 2 hypertension, you can look at getting your medication de-prescribed. If I've had many patients lose 35 or 40 pounds, begin an exercise regimen, and you can be deprescribed your hypertension medications because your blood pressure come down. There's actually, I've actually had patients where they're on a blood pressure medicine, they lose weight. We got to, while they're still on that medication, they haven't been taking it off yet. You got to be careful their pressure doesn't drop too low, and they're getting dizziness and problems like that.
Yeah.
But there's no question that weight loss can reverse hypertension and allow your antihypertensive to be deprescribed.
Well, all right, we're going to wrap this podcast up because you've got places to go, I know, and I want to make sure you're going to see your sister Andy this weekend, correct?
I am going to see Andy, who has joined us on a previous podcast.
She has. She's over the top. Yeah. I will tell you that. Andy, if you're still listening.
She is really focused on the metabolic world and, metabolic health and low carb. And we actually are going to a metabolic health conference together.
Oh, that sounds like fun. Disneyland?
It's in Florida. It's not in Disneyland, but we will see the who's who in metabolic health there.
Oh, get some autographs for me, would you?
I will do that.
All right. Well, hey, this has been the Metabolic MD /CGM Doctor with Dr. Paul Kolodzik. I'm Terry O'Brien. We'll see you again here on another episode when he gets back from sunny Florida.